Hey, good morning, everyone. How's everyone doing today? I think we ended off on our antiplatelet agents, so if anyone can remind me that is incorrect, let me know. Hanging in there, it's the best we can do right now, right? What? Either. There we go. This is what I needed. Okay. That is good. I will continue on with our anticoagulants and what? Platelet drugs. Morning, everyone. And then this is the end of material for this exam, so then next week we'll have our exam. We'll probably meet back at 9 a.m. the lecture. Of course, if you guys have any questions, put them up in the chat or in Word, of course. All right. Well, 8 o'clock. I think we'll have plenty of time to get through the material today. So we'll finish this up, and then if you guys have any questions about anything else we've covered in terms of the exam, we can certainly talk about it as well. So if you want to have sort of review time, that's fine, because we got the full 2 hours, so we can do that. So Sylvina was asking, I know that spironolactone has adverse effects to patients with hyperkalemia, but is it contraindicated to give it to someone's renal issues? Well, at least in terms of CHF, you want to be cautious there, because if you are having someone who has CHF and they have a serum creatinine greater than like 2.5, which is pretty decent renal dysfunction, then again, you're going to see that risk for hyperkalemia goes up, right? People who have poor kidney function typically can't regulate their electrolytes as well, and so they tend to hold on to stuff like potassium. So I would be pretty cautious there. Obviously, if their potassium is already above 5, in addition to that serum creatinine, I would not administer that at that point. And again, you're taking it into account with all the other medications that they're on. Like, are they on Lasix, which is lowering the potassium? Are they on an ACE inhibitor, which is increasing it? There's a lot of different kind of things at play when you're considering that. And that's why it's really important to monitor over time, because you'll find that people may not keep up with their patients from that standpoint and look at things like how renal function changes over the years you may be taking care of these patients here. And so if no one goes back and reassesses that stuff, they can get into trouble. And I see that quite often in like the adult ER, because you'll have patients who are coming from nursing homes who aren't really getting watched all that closely, and they'll have some sort of change over time, or even in the acute phase where no one's monitoring it. And so things will progress over time. They'll build up levels of these drugs, and then they come in with pretty severe toxicity. So one thing you do want to be cautious with there. Okay, so someone had a question about ipsiximab, but we're going to get into that today, so I will certainly address that question here coming up. All right, so let's talk about our antiplatelet drugs here. So, we kind of mentioned aspirin briefly, like in the last section, we were talking about angina and, vascular protection and whatnot, but let's get into the nitty gritty of these drugs here. So, hemostasis is quite important because someone's saying, are loop diuretics the best option for patients with renal issues? So loops are the best option when you want to get fluid off of a patient, right? Again, they're not great for hypertension in the long run. It can be okay in the acute phase if you have someone who is hypertensive due to volume overload. There's too much fluid in the tubes, so to speak, or the hose. So loops can be used basically with anyone with any renal dysfunction. Doesn't really matter. You're going to be able to get some fluid off of them. So that's one thing that's important to know about loops. They can be used irrespective of someone's creatinine clearance. Thiazides, on the other hand, though, they tend to lose efficacy once you get below something like 30 mLs a minute, except for metolazone. So if I had someone who had pretty significant renal dysfunction and I needed them to be on a thiazide, metolazone would be the one to use there. And so the most frequent times that I see that are often when I have a patient who has, they're on a loop diuretic, they're having some issues with kidney function, and they need some additional boost in terms of urine output. And then oftentimes I'll see metolazone added on to something like Lasix to get some additional diuretic effect. It really just depends on the situation there in terms of, like what you need to do with the patient. But for hypertensive purposes, loops aren't really the best drugs to be using for those patients. So someone did ask on the board here, how can something with a CYP3A4 substrate, or be a CYP3A4 substrate and inhibitor? I'm not sure I understand how it can do both. Well, think about how lots of people can have different roles, right? So I could be, a professor, but I could also be a student if I went back to school at my university, right? So people can kind of serve multiple roles here. So the thing to remember with that is that a drug can be a substrate for an enzyme and also inhibit it at the same time. There's nothing to say that that's mutually exclusive. And again, that means that it can affect other drugs that are being metabolized by that same enzyme. So if I were to add on something like verapamil to simvastatin, for instance, that would be an interaction. And then if I add another CYP3A4 inhibitor on board, that could affect verapamil as well. So if I add something like a macrolide or erythromycin, that could also end up increasing levels for verapamil. So again, ultimately just be careful of those drugs, look for those interactions, and make sure that you can adjust the doses as necessary for that, right? Someone says, I know statins increase liver enzymes, but do statins cause any kind of liver tissue damage? Well, like, why do you see the liver enzymes increase, right? So, you're measuring a blood level and you're getting liver enzymes. Well, where are those liver enzymes coming from? Well, they're being released from hepatocytes. So if you're measuring higher liver enzymes, it's probably because there's something that's leaking these enzymes out, usually due to cellular damage. So yeah, absolutely. When I say hepatotoxicity, that is being evidenced by having these increased LFTs, right? Because there's something going on in the liver there. So yeah, absolutely, they can cause pretty significant hepatic injury. So that's why you got to watch your doses, watch out for drug interactions and all of that to avoid any significant issues there, for sure. Good question. All right. So let's go ahead and talk about hemostasis. So obviously, if you have vascular injury, you want to be able to clot off when appropriate. We also want to make sure that we don't have too much clotting going on because of the fact that, if we have occlusion of vessels, that can lead to blockage. We can lead to breaking off of those clots, which can lead to embolus. So we want to make sure that we can clot when we need to, and then we can keep things fluid when not, right? So that's an important balance here. We're going to learn some of the different factors that go into this. And so, for instance, here, if you were to imagine the process in general, you can see if you had some sort of injury done to a vessel, you have initial bleeding here. There's going to be a whole cascade of events that are happening here that are all going to be can be influenced by medications. But initially, you're going to see there's some degree of vasospasm because the body is trying to limit how much bleeding is going on. And then you're going to start to see platelet adherence and aggregation start to occur. This is where we get a platelet plug sort of form here. And then finally, fibrin is going to be formed through our clotting cascade in order to sort of plug up that hole. And so you can kind of think about fibrin as kind of like liquid cement, just kind of holding all those platelets in place. And then once that's occurred, now that you stop the bleeding, now you can go ahead and heal that tissue. And then eventually you want to get rid of that fibrin and all those platelets. And so you have things like fibrinolysis come along and then get rid of that, right? So there's going to be lots of ways we can either enhance this in some cases, but more often than not, we're going to try to be inhibiting this because we're going to be dealing with patients with like PEs, DVTs, ischemic strokes, MI. So we want to know ways that we can try to prevent people from clotting when they don't really need to be. And so if you're looking at platelets, kind of what's happening here is that normally when they're kind of resting in this state here, you notice they're kind of circular shape, kind of globular shape, they're kind of just hanging out in the vessel. And so normally the vessel wall is able to sort of prevent any aggregation from occurring because they have certain, it's pretty smooth sort of tube there they're running through. But when you have injury there, you have things like von Willebrand's factor that get expressed, and then they start to activate the platelets. And so you'll see they actually start to change conformation as they sort of like squish in, and you see these little 2B3A receptors here start to get expressed. And this then allows them to start to kind of attach to one another. And this is what starts to form that platelet plug here. So normally platelets are not really sticky, but then once they're activated, they turn into this really sticky form. They can hold on to one another. And so there's a lot of different factors that are going to go into activation of platelets, right? So some of them are going to be important for our purposes in terms of medications, and some of them we may not be able to do a whole lot about. But some of the major ones here include things like ADP, or adenosine diphosphate, can be activating these P2Y1, P2Y12 receptors that cause activation of the platelet. Thromboxane A2 is going to be an important one that's where aspirin is going to be working at. And then there's some other ways we can we can interact with this as well. So for instance, if we can prevent platelets from sticking to one another by inhibiting these 2B3A receptors, notice here what's holding them together is fibrinogen. If we can block this, then that's also going to be helpful to prevent platelets from aggregating, okay? So we have a couple of different ways we can do that. So first one's going to be aspirin. I think most people are probably pretty familiar with aspirin as being an antiplatelet drug here. And this is going to be an irreversible inhibitor of cyclooxygenase, blocking that enzyme. And the benefit of using aspirin over something like a typical NSAID is that it is irreversible, and its effects are going to be lasting for the lifetime of a platelet. So if you were to inhibit the cyclooxygenase on a platelet, it lasts for about 7 to 10 days until you can produce new platelets. Because remember, platelets don't have nuclei; they can't form new cyclooxygenase. So the important one you're going to see is that by blocking thromboxane A2, you inhibit the activation of a platelet. Now, prostacyclin or PGI2 actually has antiplatelet effects of its own, so there is a bit of a balance there, but overall the predominant effect is going to be thromboxane A2 being inhibited here, right? And we see that, you don't need a lot of the drug in order to do this. So COX is going to be maximally inhibited about 160 milligrams a day. If you think about it, what do they normally tell patients to take for aspirin? We'll take 81 milligrams a day. Take a baby aspirin, even though they're an adult patient. The reason why they mention that is because of the long-lasting effects. You only need about 81 milligrams a day to get good inhibition. And any higher than that, you actually end up kind of balancing it more towards the side of inhibiting prostacyclin activity, which we actually want. So just know that that's why we go with lower doses of aspirin during when we're trying to prevent cardiac events from occurring, right? And now again, we'll talk later on, we get like pain management and talk more about NSAIDs, about how certain drugs may be more COX-2 selective, but aspirin itself is non-selective. It'll affect both of these here. And And so just know that COX-2 is normally something you're going to see associated more so with like inflammation. That's why we use it for pain management purposes. You know, if you have an inflamed joint or something, this can help out with that. But really just know that by inhibiting thromboxane A2, this is the main one that we're going to be looking for. That's the main activity we would like. Now, the downside of the other NSAIDs, why we don't use ibuprofen as an antiplatelet drug, is because once the drug is gone, the platelet can go back to its normal functioning because it is a reversible inhibition. So as soon as the drug's out of the system, then the platelet goes back to normal activity here. So that's why we like irreversible inhibitors like aspirin. In terms of side effect, you want to be cautious here. And typically with lower dosing, you're less likely to see some of these happen here, but these are good to know, especially if patients end up taking NSAIDs in addition to aspirin, which you wouldn't recommend to them, but they may be doing just due to their availability over the counter. But the GI stuff tends to be a problem. This is mainly because cyclooxygenase is important for producing the protective barrier around our stomach that keeps our stomach acid from eating up our own stomach. And so if you lose that, then that's where you're going to see things like GERD symptoms can occur here, peptic ulcer disease. And so two of the big causes for peptic ulcers are NSAIDs and then H. pylori. And so this is, again, one of those causes there. So if you have a patient who had a history of peptic ulcer disease, something like aspirin may be a less desirable option for those patients, right? And then obviously, and with most of the drugs we're going to be seeing today, it's going to be bleeding is going to be our main side effect, right? So bruising, bleeding, again, it's not like overt like hemorrhage they're having here. It could be more occult, right? They could see, dark tarry stools, which is indicative of an upper GI bleed. It could be, gingival bleeding while they're brushing their teeth, little things like that that may not be quite as obvious to your patients, which is why education is so important. To let them know about this stuff. So another way we could try to inhibit these platelets here is with our ADP receptor blockers. Basically, there's two receptors that are active here, so P2Y1 and P2Y12. Essentially, both of them are working on different pathways to activate the platelet, but ultimately they all, are getting to the same goal here, right? So by inhibiting ADP, by blocking those receptors there, you prevent activation of the platelet, and again, just going through a different mechanism to make that happen. So it makes sense why you could use something like aspirin in addition to one of these ADP receptor blockers because they are having synergistic actions, right? They're working together. And again, it's not uncommon you would see these two classes of drugs used during certain events, as we'll talk about just a little bit later on there, right? Also, they can inhibit the actions of fibrinogen from binding up those two B3A receptors. That's also another benefit. And they can also help out with that binding of that von Willebrand factor. So a couple of different ways that they're working, which is why they're pretty potent, probably a little bit more so in terms of prevention of platelet aggregation than you're going to see with aspirin even. We have three drugs that fit into this category. We have clopidogrel, ticagrelor, and prasugrel. And so these are all going to be pretty effective. These are all also oral agents, and so these are things you might see patients on chronically at home. I'll kind of give you some ideas in terms of which ones you're going to see more on the like inpatient side because they're usually IV infusions versus which ones you might see patients on chronically at home because they have oral options available. Obviously aspirin is an oral product that you're going to find in most people's homes or a lot of people taking. The ADP receptor blockers may be a good alternative to aspirin too. So if patients could not tolerate aspirin due to, asthma or due to, peptic ulcer disease or something, this is typically what they're going to get put on instead is going to be one of these ADP receptor blockers here. Note there is kind of a delay in clinical effects. So frequently if patients are getting this in the hospital due to like NSTEMI and they're about to go back to the cath lab, they'll probably get like a loading dose that you will use in order to get up to maximal effect pretty quickly there. And so we can use it during certain types of MIs, peripheral artery disease, angioplasty, stroke. Frequently you're going to see these being used for patients who have stents being placed in coronary vessels to prevent platelets from binding to those bits of metal in the vessels. Now, in terms of side effects you're going to be looking at, obviously bleeding is going to be one of the big things you're going to be looking for, bleeding, bruising, and whatnot. There's something called thrombotic thrombocytopenic purpura, or TTP. This is something that was a problem with a precursor to something like clopidogrel. those are more frequent. And so basically you'd have this reaction where you'd have all of a sudden this patient start getting these clots that are forming and their platelet counts are getting low, and it was actually a result of the drug. The risk for that is quite low with the agents we're talking about nowadays, like clopidogrel. So that's the benefit here. So it only happens in 0.00035%. So essentially unlikely to occur in most patients, but you still at least want to be aware of common stuff that occurs, but then also the killer stuff for medications, right? So just something to note with that. Prasugrel, again, you're going to find that with prasugrel and ticagrelor, there's probably a little bit stronger antiplatelet effects than clopidogrel. These are also like kind of the newer agents on the block, so to speak. And so bleeding risk is higher, but also they are better at preventing secondary clotting from occurring, essentially. Other things you want to watch out for with this one, with prasugrel, is risk for hypertension, which a lot of these patients might be hypertensive already. You also want to watch their lipids as well, right? Ticagrelor is going to be, again, a lot of these have very similar activities in terms of getting loading doses. I'm not going to ask you whether one's a prodrug or not. It's more just kind of for your information there. This one's kind of interesting because you can see a big increase in uric acid in some susceptible patients, which may be bad if, for instance, they have a history of gout, right? So maybe this is not a good option there if they have that history, for instance. Dyspnea is also another one. And again, some of these symptoms you might be worried about if, it could be as a result of a clot, right? So if someone develops dyspnea, you might be thinking something like a PE, right? But really could just be related to the medications that they're on. So just something to keep in mind there. Now, switching gears, going to the 2B3A receptor blockers, basically this prevents that direct connection between the platelets. Again, fibrinogen is normally what's binding these together with these receptors. And so these are going to be agents that we're seeing used inpatient, used in the hospital, typically getting patients ready to go back to the cath lab, or if they're having an in-STEMI. Really just depends on what sort of what the cardiology people prefer, what's going on with the patient specifically. So but again, these are helpful because they're very fast acting and pretty good at being pretty strong antiplatelet agents here. So anyways, the first one here is apixaban. Obviously you can tell by the name already, it's a monoclonal antibody. So it's an antibody that is targeted against these 2B3A receptors. And so benefit here is has pretty immediate onset and lasts about 18 to 24 hours after it's stopped. And remember, any of these protein-based drugs are going to be fairly expensive. So that's one thing you want to know with that. And again, you're using them in conjunction with other antiplatelet drugs like aspirin. You can use them with anticoagulants like heparin to prevent restenosis of things like, vessels that have just been used for angioplasty, for stent placement, things like that. Obviously, bleeding, thrombocytopenia can be a risk with these drugs here. And then because it's a monoclonal antibody, you can see some immunogenic reactions, right? So that can mean anaphylaxis potentially, right? Just like with any monoclonal antibody. But you can also see potentially patients may get sensitized with the first time they receive it, and then the second time they get it, maybe they have a reaction then. So again, you may want to be careful and ask patients, have you received this drug before? Look at their medical record to see if they've ever, because it may not be their first MI that they're coming for. It could be the second or third one, for instance. So one thing just to consider there, the drug either may lose efficacy or maybe, causing more of an allergic reaction due to previous exposure. Another one here is called eptifibatide. This is, again, similarly going to be an IV infusion that's going to be received in-house, typically given as a consistent infusion. The nice benefit about using continuous infusion of these drugs is you can titrate exactly how much activity you want. If you're not getting enough antiplatelet effects, then you dial up the dose. If you're getting too much, then you dial down the dose, right? And again, any of the 2B3 inhibitors can be used basically interchangeably with one another. There could be some instances where you're choosing one or over another, and I'll show you some examples of that. Now, eptifibatide, it's still a peptide, but it's not like a full antibody like apixaban is, meaning that it does carry some risk for immunogenicity, but it is lesser than being a full antibody, just because it's a smaller structure, as you can kind of see here. And again, bleeding risk and thrombocytopenia are the biggest things you're going to be looking for. And then the last one of the bunch is going to be tirofiban. This one is actually a non-peptide, so this would have the least amount of risk associated with anaphylaxis or immunogenicity, but also notice it undergoes renal elimination, so you would want to watch the renal function for these patients there. That's kind of the trade-off with this one. Less risk for anaphylaxis, but also renally dosed. So that's one thing to note. And then, because he's bleeding, bradycardia and dizziness are kind of most commonly associated with this drug. All right, those are the main antiplatelet drugs you're going to see there. Again, you might see patients go home on something like clopidogrel plus aspirin, for instance, but if they're getting something like eptifibatide, they're going to be inpatient because that's a continuous infusion they're going to be getting through the veins, right? So those are antiplatelets, right? It's important to keep the mechanisms straight in your mind because you don't want to mix up the actions here. So when I say antiplatelet, I'm meaning talking about working directly on the platelets, right? If I say anticoagulant, I'm talking about things that are working on the clotting cascade, the coagulation cascade that we're going to be getting into here. I'm sure you've covered it elsewhere, but just want to make sure that I note that delineation for you guys so that way you can kind of keep them separate in your mind because their actions are, you know, probably going to be the same. The side effects are roughly the same, but you want to know the difference in terms of their mechanisms to make sense of when you might use one versus the other, why you might use the two together, things like that. So here is the clotting cascade. I'm sure most of you have at least seen this at some point in your career so far. Remember that we have both the intrinsic and the extrinsic pathway here. Intrinsic pathway is typically due to actual damage done like within the vessel itself. So things like von Willebrand factor can sort of kick this off. But then with the extrinsic system, this is more of like an external injury damaging the vessel. Tissue factor getting exposed is sort of kicking it off. Ultimately, it doesn't really matter for my purposes in terms of knowing the specific pathways, knowing that 12 goes to 11, goes to 9, blah, blah, blah. I will point out which drugs work more so on the intrinsic system versus extrinsic because that will be important to know in terms of monitoring, okay? So again, with like our antiplatelet drugs, there's not really a good way to monitor necessarily to see how antiplateleted, so to speak, that they are, right? There's no good monitoring parameters. But for anticoagulants, we do have good means for measuring to see how anticoagulated the patient is. And that's important because, again, this is an easy way to kill somebody or harm them by having too much of this stuff on board, leading to excessive bleeding, okay? So you got to know your monitoring parameters. If you know which pathway they're working on, then that can sort of clue you in, right? So this is sort of evidence here when you're looking at APTT is going to be more seen with drugs usage that affect the intrinsic pathway. PTINR is going to be more so affecting drugs on the extrinsic pathway, okay? Ultimately, they all end up on the common pathway. So you can see factor 10 is a very important one here. Factor 2, which is thrombin, 2A thrombin, very, very important here because that will then kick off the conversion from fibrinogen over to fibrin. And then that is where we get our stable plugs, right? So you have the platelets aggregating, and then you have fibrin being formed to hold it all into place. This is like the cement that holds it all together. So I'll show you some more details why I think that's important here in just a little bit. Notice this is a positive feedback loop. So as you produce more factor 10A and 2A, that then feeds back and can further activate the intrinsic pathway here. So it's a cyclical sort of thing. And this is why we have medications that can interrupt this in order to prevent further clotting from occurring, especially if someone's having an acute event where they're actually, having a PE or an MI or something like that. Now, note that the body has natural anticoagulants in the system, and that's good because we want to make sure we're not having excessive clotting kind of just going off all the time. And so this is where a few different enzymes can be really important here. So things like antithrombin 3, we're going to talk about pretty extensively. Protein C and S, things like thrombomodulin. So we'll look at a few different examples of those as we go forward and see how they are going to be working with our medications. So the first one here, this is sort of like the OG, like old school sort of anticoagulant drug that we've had around for decades and decades. And this is heparin, and most people have probably heard of heparin before at some point. Notice here, this is basically kind of a long sugar chain molecule. It's actually quite a large molecule, and I'll show you some pictures that kind of illustrates that concept there. Basically, it's this long chain with this core of a protein, and it can really kind of vary depending on molecule to molecule how long it is. You can see here anywhere from like 3 to 30,000 Daltons long. That's just quite large for a medication. And again, when you have a big medication like this, that's not going to be able to be taken from the GI tract because the GI tract's going to tear this up, right? So into smaller components so it can be absorbed. So the drug loses all efficacy. So this is a clear example of something that has to be either given like sub-Q or IV because that's the only way it's going to have any bioavailability. So if I say heparin or if I say unfractionated heparin or like UFH, that's all the same thing, right? It just means it's the natural heparin that you and I all produce. We have now some synthetic ways of producing it such that we can have exogenous sources that we can give to patients. But just remember, you produce this already, right? Which is why it's kind of odd because people will say, oh, I have a heparin allergy, which is hard because you produce heparin, right? So when you hear that, it's not that the patient is mistaken. It's just the fact that they're probably not being quite precise enough in their language, and it's no fault of their own because they probably don't know that. But when people say they have an allergy to something that is a normal product that that patient is producing, so like if someone says I have an epinephrine allergy, or if I have an insulin allergy, frequently what they really mean is that they have an allergy to something in that medication product, right? So for instance, if I have someone who has an epinephrine allergy, it's usually because there's like a sulfite preservative in the product. That's what they had a reaction to, okay? If you can find a preservative-free product, then they have no problems with it. So little things like that. So even though you hear things that sound silly, there probably is something behind it. That's why you want to do that further investigation as a good clinician, which I know all of you are going to be. So anyway, so getting back into unfractionated heparin, its mechanism here is it works with antithrombin 3, and it's going to help to facilitate antithrombin 3 to work like 1,000 times faster, right? So it's a big facilitator of this enzymatic interaction where it inactivates factor 2A and 10A. So that's the biggest players there, right? So think about like you're driving a car, keep your hands at 10 and 2, very important. Sure, all of you do that, very safe drivers. Same thing here, 10 and 2 are very important clotting factors to inhibit, which makes sense because they're both part of that common pathway, right? Now, additionally, unfractionated heparin or just regular heparin is going to have activity against 9, 11, and 12, okay? I do expect you to know which clotting factors that the drugs work on specifically. Like I said, I'm not going to ask you the specifics on the order of the clotting cascade. That's for another class, I'm sure. But 2, 10, 9, 11, and 12. Those are the main ones that heparin is going to be affecting here, right? So basically, it helps to facilitate antithrombin 3 to inactivate those clotting factors much faster than it would otherwise, okay? Once antithrombin 3 is done, heparin can be released. It goes off and then binds with another molecule and can do this thing all over again, right? Here's what this would look like. Imagine you have unfractionated heparin come along, binds up with antithrombin 3 here. You can see that it just facilitates this binding together much more quickly. So factor 10A can be inactivated, factor 2A can be inactivated as well, right? So 10 and 2 are sort of the most important ones here to note. So, we've had animal sources for this before. So, for instance, some sources you can still find that can actually come from porcine intestinal mucosa or bovine lung. So that's important too. Most of the products you'll see nowadays are actually recombinantly made, but I've had cases where patients could not receive that product. They had to get the animal product. It's usually a little bit more expensive. But also think about things like, patients' religious concerns. Can they consume products with pork in it? If not, then they can't utilize that particular source of medication. So again, sort of those things don't come up all the time, but it's a good thing to consider too. So not just focusing on a patient's allergies and past medical history, but also what are their spiritual and societal sort of concerns, because that may preclude you from using certain medications there. So for instance, like the one that comes up probably most frequently is like Jehovah's Witnesses and getting blood products and things like that, being a challenge to work around for sure. So anywho, so as I mentioned, you can't give heparin orally because the GI tract would just tear it up. So usually given either IV or sub-Q. And typically you're going to see if you're using a sub-Q, that's going to be more for prophylaxis. And so that's another important thing to consider too, is how are we using these drugs here? Are we using it to treat an acute clot that's happening right now? Or are we using it for prevention of clots? And so if it's a preventative, then it's okay if I give it sub-Q and it takes a couple hours to kick in because I'm just trying to prevent something from occurring. And so when would you use this, right? For prevention of clots, if I have someone who is in the ICU and they're laid up in their bed 24 hours a day because they're intubated. They're not moving anywhere. Venous blood is sort of just becoming static in the legs. They can form a DVT, right? That's a good option to use for prophylaxis. If I have someone who's going on a flight for, say they're going from, I think the longest flight in the world is from like LA to Australia. If they're on that flight, then they may be at risk for developing a clot, right? So they can use heparin in that instance there. If they're pregnant, you can use heparin. So, but for acute management of a clot, they say they come in with a PE or DVT, then this is where we're going to give IV infusions because that's going to be faster acting and be able to prevent any further clotting from occurring there. So again, and if you had a pregnant patient who required anticoagulation, heparin is normally the first one we're going to go with here because it actually doesn't cross over into the placenta. It doesn't affect the baby as much as some of the other medications might here. Do note that with renal failure especially that you can see increase in half-life, so you do want to monitor for the anticoagulation effect of this, and I'll talk about some examples of that here in a moment. So how do you monitor for heparin's effects? We do APTT, which is the activated partial thromboplastin time. Typically, you're going for an APTT ratio, and again, this is measured in seconds. And so typically, you're going to be looking at your patient's APTT and then comparing that to what the normal value would be, or maybe what their baseline would be. A lot of protocols out there you will find actually refer just to the actual value itself that you're shooting for. So it really just depends on the lab you're dealing with. It depends on what kind of protocols you have to deal with. So normally you're going for like a ratio like 1.5 to 2.5 times normal, right? So that means that the time it takes for those for the clotting to happen is extended by about 1.5 to 2.5 times, essentially, right? And again, this is a measure of the intrinsic pathway. Remember, because this is affecting 2, 10, 9, 11, and 12. 9, 11, and 12 are mostly found in the intrinsic pathway here. So this is why we use APTT. I can tell you right now, need to know this stuff on the test. So if something has an antidote for it, and if what the monitoring parameters are going to be for these drugs, you got to know, okay? Because this is very important. And again, you can very easily kill someone with these medications. And so this is why I kind of focus on the safety aspect so much, because they can be dangerous in the wrong hands, right? I want to make sure you guys have the right hands. So anyway, where to use heparin? Lots of things. Anytime you want to either prevent a clot from occurring or actively treat a clot that's occurring right now can be very beneficial. So, thromboembolism, PE, MI, angioplasty, use heparin all the time. So bleeding is going to be the most common thing you see there. In terms of reversal, we do have a drug that can help out with that, and this is called protamine sulfate. So if you had someone who accidentally received too big of a dose of heparin, they're having active bleeding, this is where you can utilize something like protamine. You would want to be knowing that in terms of like the correct antidotes for that. And so the other thing to worry about too, and this is sort of a unique side effect with heparin, is something called heparin-induced thrombocytopenia, or HIT. And while this is not something that happens extremely frequently, you do want to be watching out for it because it can be quite deleterious to your patient if it does occur and you're not watching for it. So what is this? Well, basically, your body develops this antibody to the combination of two things. So this combo of heparin, something called platelet factor 4. When you develop those antibodies, it actually will then activate platelets, which is odd because you're like, well, I'm giving an anticoagulant drug, I'm preventing clotting from occurring, but then you're activating all these platelets with this antibody. And so that's why you develop thrombocytopenia. So it's a heparin-induced thrombocytopenia. And so you're giving an anticoagulant, but now you're having all these clots that are forming because all your platelets are being used up. And so can be quite deadly if not caught and managed early. And so typically you have to discontinue the heparin immediately, and they can never receive heparin again once they have this. It's like almost like having a heparin allergy. And then we're going to give them an alternative anticoagulant. So here's a few options here. I'll go over these ones more specifically in just a few moments. Typically, you're also going to want to avoid our low molecular weight heparins. We're going to talk about what those are in a few moments, and also warfarin until the thrombosis has been resolved. Note here the time frame. Normally it's within 5 to 10 days after initiation of therapy. So if someone's on heparin drips for a long period of time, say 5 to 10 days, you got to watch out for that. So you're looking at their CBCs daily anyway. Make sure you watch the platelets. And if you see something like, 50% drop, something weird's going on. You need to investigate that further and probably get them off of the heparin. All right. So what would happen if you chopped up a heparin molecule into smaller pieces? Well, then you would get low molecular weight heparins. Okay. So these are beneficial from a number of different standpoints, which I'll talk about. But essentially, these are just smaller forms of heparin. So unfractionated heparin is a big long molecule. Low molecular weight heparins are just chopped up. And so the main one you're going to run into, there's a few others that are out there, but honestly, I've never seen the other ones clinically. But enoxaparin or Lovenox is the most common one you're going to run into. So basically what you find is that because it's a shorter molecule, it tends to have less specificity for all the same clotting factors that unfractionated heparin has. So it still affects factor 2, but the main thing that it inhibits is factor 10. So 10 is going to be the main thing that's going to be affecting here. And notice it doesn't really affect 9, 11, and 12. Okay, so the monitoring parameters are going to be much different for these. You can see the ratios here with unfractionated heparins about 1-to-1, with factor 10A and 2A activity being inhibited. With low molecular weight heparins, it's probably like a 2-to-4, 2-to-4 times more selective for factor 10A than it is for 2A. And that kind of makes sense when you look at it being a shorter molecule here. It just doesn't really help to facilitate that binding to 2A very much, right? Or as well as unfractionated heparin actually might. So the benefit, the big claim to fame with low molecular weight heparins was you didn't really have to do monitoring for them. Instead of monitoring APTT, you just basically gave them a weight-based dose. You didn't have to monitor. It was great. You didn't have to worry about their APTT ratios. You didn't have to worry about a continuous infusion. It had a longer half-life. You basically gave it every 12 hours. This again can also be used for prophylaxis or treatment, but it was much easier to use. And so a lot of people liked it for that purpose there. And again, it doesn't really affect APTT all that too consistently, because it doesn't affect those intrinsic clotting factor or clotting factors, right? So it doesn't affect 9, 11, and 12. So that's why you can't use APTT for that. Now, whereas with unfractionated heparin, you'd have to have pretty severe renal and hepatic dysfunction before you'd really see any big changes in terms of elimination. For this one, it's almost entirely renally eliminated. So you have to really, really watch out for the renal function. So you may not have to monitor APTTs, which is nice from that standpoint, but you definitely want to look at their creatinine clearance to make sure that is sufficient to clear the drug, because otherwise they're going to hold on to too much and they're more likely to bleed. Okay. Now, if you do need to monitor for its effects, if you had someone, say for instance, in renal failure, or if they were at the extremes of weight, say they're in the very high side or the very low side, or like we do a lot in pediatrics, we typically do routine monitoring just because with peds, they're a little bit more of a heterogeneous population. Want to make sure that they're, going to be, not everyone's processing these drugs exactly the same. Then what we use is called anti-factor 10A. Okay, so with unfractionated heparin, classically you're using APTT. For low molecular weight heparins, you're using anti-factor 10A for a monitoring parameter. Okay, and again, you don't have to use it for everyone, but for those special cases, that's when we're going to bust this out. And so again, you're going to typically see less bleeding than with heparin with the low molecular weight drugs, and some small risk for HIT, but it's a lot less. But keep in mind, if someone has a history of HIT, do not want to use a low molecular weight heparin. There's going to be cross-reactivity that's there, there's a chance, and so you don't want to be using that. Okay, I'll talk about the drug you can use instead. So that drug is going to be paranox, which is basically if you cut down a low molecular weight heparin even shorter, and just got the pentasaccharide sequence, which is 5 sugars long essentially, you get paranox or Rixtra. And this one has just activity against 10A, no 2A activity at all. Okay, so the benefit here also is no routine monitoring is required. And you're also going to find that similar to enoxaparin, you can still use anti-factor 10A to monitor for it. It's still going to be really eliminated like enoxaparin is, so you still have to watch out for that. So, and typically what we're going to use this for is for patients who may have had HIT in the past, and you could use this instead because there's a very low cross-reactivity rate. So if you had to use some sort of anticoagulant, Rixtra might be a good option there. And so you'll typically see this used a lot, like if any of you guys are going to work in surgery and orthopedics, using this for, along with like enoxaparin for prevention of DVT after a hip or a knee replacement or something like that. But they can be used for active clotting as well. So if you had someone who's coming in for a PE, these can also be used just as well as heparin can be. All right. And again, these are all sub-Q IV products we're talking about here so far. Now, what if you had someone who actually ended up having HIT due to heparin? What can you use instead, right? So they still need to be anticoagulated because they're having all these platelets being activated and having this clotting occurring. Well, you can use what we call a direct thrombin inhibitor, and just like the name states, it's going to be affecting factor 2 predominantly. And so we have 3 drugs that fit into this category: leparudin, bivalirudin, and then argatroban. What's kind of interesting with this one is that leparudin and bivalirudin are actually based off of a product called heparin, which is actually a product that is formed in the salivary glands of leeches. So if you ever hear about like old-timey medicine where they used to do bloodletting with leeches, so that we're actually trying to mimic some of the products there. So I always like to point out whenever we have an animal or a plant source for medications, I always think that's kind of interesting. So yeah, so basically leech spit, we're able to isolate out the product, and now we have leparudin and bivalirudin, and then argatroban was sort of also ran in that category as well. So as I mentioned, they're going to be affecting factor 2 predominantly. You can still monitor these with APTT. So they do have some activity against some of the clotting factors and the intrinsic pathway, but again, 2 is the main thing here. So you can monitor APTT. These would typically be given to like continuous infusions. With leparudin and bivalirudin, you would want to watch renal function because that could lead to accumulation. And then for argatroban, this is more hepatically excreted, so this would be better for someone who had like renal dysfunction, for instance. All right. So next off, and then we have kind of the first oral anticoagulant that we've had on the market. And again, we've been doing this for decades now. And this is warfarin. So it actually is an acronym. It stands for the Wisconsin Alumni Research Foundation. So, when you guys want to go impress a potential significant other, you can wow them with your knowledge and tell them, actually, did you know that warfarin stands for the Wisconsin Alumni Research Foundation? They're going to be wowed by your knowledge, and I think you're really gonna, cinch that deal there. I'm just kidding, obviously. No one would be impressed by this knowledge except for me if you went and told me that. But regardless, you can see here that it was an accident we found warfarin. Actually, it actually had to do with some of this spoiled clover that these cattle were ingesting at the University of Wisconsin. And they were eating, and they noticed they had these bleeding cows, and they're like, "What in the heck is going on here?" And they realized it was a product called dicumarol. And then from then on, we were able to then utilize products in that family as a rodenticide, right? So actually to kill rats, and we still use warfarin-like products in a lot of rat poisons you're going to find out there. Rats actually don't have a vomiting reflex, so once they ingest it, they basically just can't get rid of the drug, and they bleed out, and they die in your walls or wherever, which is kind of a bummer. But you don't want any rats around, this would be the case, the drug for you. And then afterwards, we realized that, you could actually give it to people and actually utilize it for its anticoagulant effects. And actually, what's interesting too is the reversibility of the drugs here, right? And so you notice we've only had really one antidote we've talked about so far, using protamine for heparin, right? Protamine works a little bit for enoxaparin, but it's not really that good at coverage. But for all the other ones, there's no real good antidotal drugs here. This is going to be one big exception to that, which is important because if you have a patient who's coming in for drug-induced bleeding, you want to make sure you can do something about that. So I'll talk more about that in just a few moments here. But regardless, this is where we get warfarin. Coumadin is the brand name you'll probably see for that most commonly. So what does warfarin do? Basically, it's a vitamin K antagonist. Normally, most of the clotting factors you have are produced in the liver. And so some of them are dependent on this recycling reaction of vitamin K in order to produce them. So you can recycle vitamin K from its oxide form and reduce it down. You can help out with the production of things like prothrombin, and then it gets cycled back through. Okay, there's an enzyme called vitamin K epoxide reductase, and that is what is being inhibited by warfarin. Okay, the warfarin inhibits vitamin K epoxide reductase, and you cannot recycle vitamin K and thus produce new clotting factors. The main ones that get affected here is factor 2, 7, 9, and 10. Okay, 2, 7, 9, and 10. What you notice with that, 2 and 10, as part of that common pathway, that makes sense. Factor 7, though, is a big player on the extrinsic pathway. So this means our monitoring is going to be different than what you would see with heparin. So that'll be evident in just a few moments here. But basically, by inhibiting vitamin K, cannot produce these new clotting factors, and thus you're going to be anticoagulated through that. Note that while heparin worked on existing clotting factors with antithrombin 3 to inactivate them, this does not do anything to active clotting factors. If there's already clotting factors out there in the blood, warfarin doesn't do anything to them. It just decreases production of new clotting factors. That is a key distinction there because that'll clue you into the onset of action for the drug, and this is going to be much slower than something like enoxaparin might be, right, or heparin might be. Here's another picture, just kind of showing you the same thing here. Note there's going to be 2 enantiomers of warfarin. I know we talked about enantiomers briefly back in the summertime. That basically means that, you know, when you have certain molecules, they can have a handedness to them, as they say, a left-handed and a right-handed form to them. Notably here, the S form of warfarin, the left-handed form, is actually the more potent one at blocking vitamin K epoxide reductase or oxide reductase. And so you can see here that there's going to be a lot of CYP interactions that can be affecting warfarin, okay? So CYP interactions are another important thing to note that we'll be looking at here in more detail in a moment. So anyway, so what we can see, as I mentioned, when you get therapeutic levels, you're going to have decrease in vitamin K dependent cofactors. So 2, 7, 9, and 10 primarily. We'll also see protein C and S can be affected as well, which is important here in a few moments. Again, no effect on existing factors that are out there in the blood. So it takes like a few days before warfarin really kicks in. Maybe like 2 to 3 days before you really start to see its onset of action there. So what we're going to see is that the reason why it takes some time is because the clotting factors that we have a certain half-life to them. You know, it can be anywhere from, you know, say 4 to 6 hours for factor 7, but if you look at factor 10 and 2, you know, it can be days potentially. So it takes time to deplete those clotting factors as warfarin is working to prevent their production there. Now, notably, what's interesting here is that protein C is actually a natural anticoagulant. So you want protein C around because it's a natural anticoagulant, prevents you from clotting. However, what you're going to find is that this is one of the first ones that gets depleted. So initially, when you put someone on warfarin, you actually can put them into a procoagulant state, which may not be great if the reason why they're getting put on is because they just had an MI or PE or something like that, right? So again, for the full antithrombotic effects, it takes like 5 to 7 days, but you'll certainly see some changes within, you know, say 2 to 3 days or so. So that's why you gotta be really careful when using this for someone who's had an active clot, okay? Now, normally what we'll do is something called bridging therapy. I'll show you an example of what that looks like here. So if you were to look at someone who was, say for instance, you know, we're looking at anticoagulant level on our y-axis here, and then we want to look at, let's look at our anticoagulant level on the y-axis here, and then we're going to do, on the x-axis here, we're going to do time. Now imagine you had someone who's coming in and they were on a heparin infusion for let's say you had a young lady who came in, say 18-year-old female, who's taking birth control, which is estrogen based, and all of a sudden she develops dyspnea and chest pains. She comes in, she's a pretty classic PE. We put her on a heparin drip in order to prevent any further clotting from occurring there. So if you imagine what her clotting levels are at now, she's sort of sitting here with the heparin, and we're going to use heparin activity in red here, right? So what you're going to see here is you have your normal sort of heparin activity. She's anticoagulated. Things are really good, right? If you were to go ahead and then stop that infusion, drop it down, and then you were then to start up warfarin, say here, it's going to take a long time before it really starts to sort of kick in, right? You can kind of see this. So there's a period of time where the patient is sort of not protected. And if anything, they're going to be in sort of a prothrombotic state to where they can have a recurrence of clot, right? Which would not be great. So instead, what you can do is something we call bridge therapy, where basically they're going to be on the heparin for a while and eventually you're going to discontinue it and it'll kind of fall off. But a couple of days beforehand, what you're actually going to be doing is starting up the warfarin. So while they're on heparin, they'll be on warfarin at the same time. So by the time that you cut off the heparin, the warfarin's already going to be at the anticoagulant effect is already kicked in, unless you have no drop in coverage here in terms of anticoagulant activity, okay? So again, you're giving two together, and you may think, well, that's going to put the patient at risk for bleeding. Not really. It kind of is going to take a while for them to get to that point. And even though they're depleting that protein C, which is an anticoagulant, the heparin's still there. It's still preventing clotting from occurring, excessive clotting from happening. So again, it's called bridge therapy, okay? the need for this is starting to kind of change a little bit, and I'll tell you why in just a few moments here with some of our newer agents that are sort of shaking up things and how they're being done. If that doesn't make sense, let me know. If you hear that term bridge therapy, that's what we're talking about. So anyway, so warfarin was used for so long because it was an oral anticoagulant. So if you had someone with like AFib or something and they needed to go home, they couldn't be on heparin long term because it just didn't make practical sense to take that sub-Q for the rest of their life. So warfarin was a good option for those patients there. But again, there's a lot of downsides. Monitoring is really important. You'd have to we'll talk about monitoring parameters here in just a few minutes, but sometimes, and like one of the first things I did when I was on rotations was to basically I spent 2 months in a Coumadin clinic, and that's basically where you'd have patients come in, you talk to them about their diet and all this kind of stuff, and check their INR and see if they're in range, and if not, then you have to adjust their dose, have them come back the next week and do it all over again. I have patients, that was an 8-week rotation, and I think I had one patient who was there every single week, right? Which is pretty disruptive to your lifestyle if you got other things to do, like work, for instance. So anyway, point being is there's a lot of drug interactions to watch out for. So for instance, it's highly protein bound to albumin. So if something comes along and kicks warfarin off of that albumin, then more of it's free to interact with the liver to cause anticoagulation. And it's also metabolized through several CYP enzymes. The primary one here, this is the more clinically important one, is CYP2C9 because warfarin has more anticoagulant effect overall. So if you have something that inhibits this, something like sulfamethoxazole and trimethoprim, you can end up seeing big increases in bleeding risk. Okay. Also, some degree of 3A4 activity is going to be affecting this as well. So if I had someone on verapamil for AFib, for control of AFib and warfarin, I can end up seeing increased bleeding effects if I'm not watching and adjusting their levels appropriately. Okay. Warfarin also is contraindicated in pregnancy, so don't use it there. And most patients who are on this are probably not going to be breastfeeding either at the same time, but we can talk more about that in pregnancy later on. So drug interaction, things are going to decrease the actions of warfarin. So this is going to put your patients at bigger risk for clots by decreasing the actions here. So anything that increases the uptake and metabolism of vitamin K, right? So we're going to see here that if we have more vitamin K coming in, that's going to cause the warfarin to be less effective because your liver can utilize vitamin K coming in from the GI tract to produce those clotting factors. It's that warfarin prevents the recycling of it, so you can't utilize it again. Okay, that'll be important. Anything that upregulates the metabolism of warfarin is also going to decrease its action. So if I had a CYP2C9 inducer or a CYP3A4 inducer, that would also decrease its actions. Okay. And then anything that could increase the synthesis of clotting factors, things like that, which is not clinically as important here. But just note that you can diminish the actions of warfarin by actually giving replacement factors. I'll talk about that in here in just a few moments, right? But anyway, so things that can alter those actions there. So things that can actually lead to increased actions of warfarin. So this puts you at bigger risk for bleeding, right? Because now the warfarin's working better. If I'm inhibiting CYP2C9, this is one of the big ones. If I have any kind of protein binding interactions where that protein binding has been diminished, so that I have more free warfarin, that can affect it. And then anything is decreasing vitamin K intake. So one of the important things to know is that the gut bacteria is actually a very important source for vitamin K for us. So if I have someone who's on antibiotics, for instance, and I disrupt the gut flora, that can lead to less vitamin K intake, and that can make the warfarin work more effectively, okay, which can lead to more bleeding. And then liver dysfunction, having low-level clotting factors can lead to increased actions, more risk for bleeding, and then just being elderly in general can also increase that activity. So again, good to know if I give you a question on the exam, if I say a patient is on a CYP2C9 inducer, what is that going to do to the activity of warfarin? Is it going to be diminished? Is it going to be increased? Something like that, right? You should be able to kind of intuit that out based off of what we're talking about here. Now, how do we monitor for warfarin effects? That is where we're going to use the PT-INR. PT is prothrombin time, and INR is basically what we call the international normalized ratio. It's just something that we use to compare the patient's PT versus a reference and get a ratio there. So obviously, if you are not taking warfarin or any sort of anticoagulant drugs, your INR right now is likely 1 because you have a normal PT Should not be altered. Like 1.1, 1.2, something like that would be perfectly reasonable. We're normally shooting for somewhere in the 2 to 3 range, okay? Now, again, I normally don't tell you to know a lot of drug levels and things like that, but warfarin's one you got to know. So for the majority of patients, an INR of 2 to 3 is considered therapeutic, okay? There's some instances, and I think when I put here a little bit later on, but there's some instances where you want to shoot a little higher, and that's going to be for patients who have things like mechanical heart valves, or if they have some degree of like warfarin resistance. They will go for like a value of 2.5 to 3.5. Okay, so normal, no warfarin is 1. A value of 2 to 3 is considered therapeutic for probably like 95% of your patients, and then some will require 2.5 to 3.5. A little more aggressive treatment there. So if someone comes in with an INR 5, that is abnormal. You need to be doing something about that. If they come in and they need an INR of 2 to 3 because they have AFib, and they come in and they have an INR of 1, that's also a bad thing, right? And so be able to sort of figure out like, okay, well, what's my INR going to be doing if I have some of these drug interactions here, right? So if I have someone who has CYP2C9 inhibition, right? So I give someone, say, sulfamethoxazole, trimethoprim, I give them Bactrim for a cellulitis, okay? So I'm inhibiting CYP2C9, which means my levels of warfarin should go up, right? Because I'm inhibiting metabolism. So levels of warfarin go up, which means I'm inhibiting more vitamin K utilization. I'm producing less clotting factors. That should make the INR also go up, right? So that's going to lead to someone having a higher INR, bigger risk for bleeding, right? Because warfarin's being more effective. On the other hand, though, what if I had someone who started taking high amounts of vitamin K, right? And so what are some foods that are high in vitamin K? You think typically about your green leafy vegetables, right? You think about kale and spinach and collard greens and all this kind of stuff. That is going to get more vitamin K into the system. I can produce more clotting factors. That's going to cause INR to go down, okay? So again, very important. Diet is extremely important with warfarin, and consistency is really the name of the game. I don't know if any of you guys are dietitians in the class. I always have like 1 or 2 of those every year, but you probably know this as well, that diet is so important for these patients here. Now, some patients will be naturally sensitive to warfarin, and it may actually do with some of their pharmacogenetics. So for instance here, if they have certain CYP2C9 alleles, they may lead to less efficient metabolism, meaning they can actually have more sensitivity to the drug. For a given dose, they're going to have a higher INR than other people who don't have that mutation, right? So toxicity is bleeding is the main toxicity you're worried about here, right? So you want to know the signs and symptoms, and education is extremely important here. So that way, if you notice a patient, let them know, let their family members know too, right? Because like one of the big things you worry about would be something like a hemorrhagic stroke, and a patient may not know they're having one, but their family member might notice if all of a sudden their face is drooping or they're having altered mental status, something like that. So these are all things you want to make sure you're educating on. Looking for dark tarry stool or bright red blood in their feces, looking for hematuria, looking for excessive bruising, all these things here to warn patients about. Now, if you can keep them at a therapeutic range, like 2 to 3, as I mentioned, for a majority of patients, it's major bleeding is less than 5%. Yeah, it's certainly increased bruising, but nothing too major. As you start to get the INR even higher and higher, notice here, this is again another narrow therapeutic drug. Your risk for serious bleeding, intracranial hemorrhage, etc., goes up pretty significantly here. So it's good to know the antidotes. And to be honest, this is one of the easier drugs to reverse because, basically I just give the patient what they're missing. So if they're having issues, the INR is high, I can give them some vitamin K. Another name for that is phytonadione. Give them vitamin K, and that can help to start to reverse that. But remember, that takes time to kick in. So vitamin K is slow acting. It's still important for them to get on board, but it's slower because it takes time for them to produce new clotting factors using that vitamin K, right? I mean, could I give them a kale salad? Probably, but that's not probably going to be the most efficient way to do it. Give them an IV dose, sub-Q, whatever you got to do, right? If they're having any serious bleeding at all, that's where you're going to use FFP, right? Fresh frozen plasma. This is something being donated by other humans, and they will pool that plasma together with all those nice clotting factors, and you can give that to the patient and reverse them immediately, okay? So serious bleeding, Any INR, they're going to get FFP plus vitamin K. Vitamin K is going to take a few days to kick in, hours to days to kick in. FFP is going to work immediately. Okay, just know that. Obviously, as well, we don't want to use this in pregnant patients. We know there's birth defects that can happen here. And then we can see skin necrosis that occurs over time. This is mainly due to deficiencies of protein C and S. So, as I mentioned, warfarin is highly diet dependent. And when I worked in the Coumadin clinic, it was in Putnam County. It was in Palaca, Florida. I don't know if any of you guys are familiar with that. It's actually I'm around there from around there originally. If you can't tell by my accent, but those are kind of salt of the earth kind of people there, and so a lot of them, their main source of nutrition was from stuff they grew in their backyard, right? And so it was a lot of collard greens, a lot of kale, a lot of spinach, all that kind of stuff, just like my grandparents did. And so it was a big challenge, right? Because they may go from week to week and have wildly big fluctuations in how much vitamin K they're intaking through their diet. So education is critically important there. Got to make sure they're being consistent. They don't have to cut it out. They don't have to add in more. They just need to keep it consistent, okay? But it's frequent monitoring. You have to have these people come in sometimes once a week until you get them in range, and then you can sort of start backing it off. A ton of drug interactions, but it was very easily reversible. That's the benefit there, right? Nowadays, though, we have a new class of drugs here called the NOACs or the DOACs, depending on how you want to call them. So it stands for new oral anticoagulants, NOAC, or direct oral anticoagulants, DOAC. So there's three in this category here. There's dabigatran, rivaroxaban, and then apixaban. So dabigatran or Pradaxa is going to be a direct thrombin inhibitor. So you can kind of think about this similar to what you would think about with like lepirudin, bivalirudin, except this is going to be an orally available agent here, right? And so this was coming out probably around the 2010 to 12-ish sort of time frame. So this really kind of revolutionized things because of the fact that you don't have to monitor INR with these patients here. You can just put them on a fixed dose and they're kind of good to go, which is very handy from a patient standpoint. You could use it for DVTs, PEs, AFibs, I mean, all kinds of things. However, there really wasn't a readily available antidote. That has now changed. There's an agent that is a monoclonal antibody made specifically for dabigatran, but it is really expensive, and depending on the hospital you go to, they may or may not be carrying it, right? Because this is not used as widely as something like warfarin. And every hospital you go to is going to have vitamin K. Everyone's going to have FFP, but not everyone's going to have this monoclonal antibody. So just one thing to note there. Also note, some GI effects, but bleeding is going to be the biggest adverse reaction you're going to see with this. But and also watch out for the creatinine clearance because it does require some dose adjustment. Okay. Rivaroxaban or Xarelto is going to be a factor 10A inhibitor. You can kind of tell because it has X in the name there, so it makes sense to be factor 10A. Similar indications as you would see with dabigatran here. Again, the mechanism is the only thing that really differentiates it. Now, bleeding, again, no easily available sort of antidote to this drugs here. Sometimes we can use what we call prothrombin complex concentrate, or PCC, which is basically even more concentrated form of FFP. That has some activity, but again, it's not the most easily reversible thing that's out there. So, the question is like, well, when would you use this versus warfarin? A lot of it's going to be patient dependent. A lot of it's going to be based off of, risk versus benefits there. If I had a relatively young patient, if I had that 18-year-old who was on birth control and developed a PE, and she needs to be on 3 to 6 months of anticoagulation after the fact, she doesn't have to come back in for INRs all the time, right? Give her something like this, and it's perfectly reasonable. And if I had an older patient, though, who's more likely to like fall in the shower and hit their head and have a intracranial hemorrhage, and I can't reverse this stuff as easily, that may lead me to more using something like warfarin. So, again, really is going to be provider and patient dependent in a lot of cases there. And then apixaban we have here, similar indications as I mentioned. Bleeding, again, can be used partially reversed with PCCs. And this one actually is going to be a substrate for CYP3A4. So this does mean it would want to look out for interactions in case something else inhibits it. And obviously, your bleeding risk would go up in those cases there, right? Anyway, so that's it for this section here. That's it for the second test in terms of material. So I want to see what questions you guys have regarding that. Someone put a question on here: can abciximab cause anaphylaxis? And that is yes, absolutely. Any kind of monoclonal antibody can cause anaphylaxis potentially. But what other questions do you all have? And it was relatively short. And again, a lot of this seemed like it was a lot more material for this exam, but a lot of it was kind of review of the same drugs, right? So when we talk about angina, like a lot of us are like covering the beta blockers and the calcium channel blockers we'd already seen, ACE inhibitors and all of that. So I think a lot of it's very, there's a lot of cross coverage there between the different topics. I think that kind of helps out with the repetition and kind of learning the products there. But what questions do y'all have? Or I might just be that good and I've educated you so well you have no lingering questions at all. It could be it. Or you're volume overloaded with information. That's a likelihood as well. Nothing at all, huh? Well, I will let you go so you can have your, extra time. So get that prescription assignment done. Oh wait, you have one? Yeah, absolutely. Go ahead. I'm gonna be on for a few minutes here. Get that assignment done. We'll have the test next week. We'll reconvene at 9 o'clock. So we can get the exam finished and we'll continue on with the last section. So, congrats, you're almost 2/3 of the way done with Pharm 1 at least. And then let's see, what do we have next section there? We have cardiology, oncology, and GI. So that'll be decent bit of stuff there. So that'll be good. It'll be set. Katie's asking, can you explain how thiazides treat hypercalcemia but also cause it? So they don't treat hypercalcemia. So that's the thing that's confusing. And I get this every year, so don't feel bad if it sounds confusing, because it is. So thiazides don't treat hypercalcemia. What they can treat is if patients are having a lot of calcium collecting in the renal tubules, leading to precipitation of calcium crystals, causing that nephrolithiasis, causing kidney stones down further. That is what thiazides are helping with, because they are trying to reabsorb that calcium from the renal tubules, so that way it's not there to precipitate out, essentially, right? So if you had someone who had hypercalcemia to begin with, and that was the cause for their stones, then you could use the thiazides for that. Is it going to worsen their hypercalcemia? Probably to a small degree, but again, that's what you'd be monitoring for. Okay, just depends on the patient, right? Depends on age and other concomitant disease states. If they have any issues with the parathyroids, kidney function, all of that. So again, not a treatment for hypercalcemia, but can treat one of the sequelae of hypercalcemia. Put it that way. What other questions do you all have? So again, like, know your interactions, especially if I say something the CYP3A4 inhibitor, inducer, etc. Like, know that stuff, because it's probably going to come up, because I think that stuff's important. Differentiate based on your mechanisms. Know how a non-DHP and a DHP calcium channel blocker, how they are different and why are they different, right? Why do they act different? What does one cause reflex tachycardia but the other doesn't, right? Be able to intuit that based off of the mechanism. Someone said, can you explain how warfarin is a procoagulant in the first 48 hours, right? So that has to do with depletion of protein CNS. If you look back at the PowerPoint, if you look at the time frame here, the first clotting factors, or the first factors you're going to be depleting are going to be the ones with the shortest half-life, because they get cleared out of the body the quickest. So things like factor 7 has relatively short half-life, and so does protein C. Protein C is a natural anticoagulant. So if you lose that, that puts the patient into a more procoagulant sort of state there. Factor 7, while would be depleted quickly, is not nearly as important as the activity of factor 10 and 2, for instance. See, Madeline is saying, for cardiac patients, how can we use any nicotine replacement agents? It says caution, but not contraindicated. Yeah, so the issue with that would be typically their blood pressure more than anything, because nicotine tends to have a hypertensive effect. So for those patients there, you're monitoring, right? So they're typically checking their blood pressure anyway. You'd be monitoring to see if it's going up, down, etc. But again, remember, for those patients who are already smoking to begin with, which might have been a risk factor for some of their cardiac conditions to start with, you're replacing what they're normally using, right? You're not giving them more than what they already had to begin with. So you're replacing that initially and then titrating it down. So if anything, you really shouldn't be seeing any increased nicotine effects because, again, it's just a switch from one nicotine product to another. Just that this new one you're putting them on doesn't have all the nasty tar and other kind of stuff they're breathing in. And then again, they can titrate down over time, right? Hope that makes a sense. Just let me know. Ideally, it'd be nice if we could do no nicotine whatsoever, but that is a challenge, and many people do fail that. So, Sylvina's saying, just to be clear, ACE and ARBs are good for diabetic nephropathy, but not for acute kidney disease, right? So remember how they're working. So long term, they prevent kidney damage over time, right? They can slow progression of kidney disease. So if you have someone who has chronic kidney disease, diabetic nephropathy, they probably should be on an ACE inhibitor, or ideally, if you have someone with diabetes, you could put them on an ACE long before they have diabetic nephropathy to try to keep the kidneys working for longer, right? However, if you have someone who is really dependent on angiotensin 2 to constrict that efferent arteriole, right, to keep that pressure in the glomerulus up so that it can filter effectively, and you lose that all of a sudden because you have now inhibited ACE2 or ACE or angiotensin 2, right? Then all of a sudden that efferent arteriole opens up wide and the pressure in the glomerulus goes down. There's less filtration pressure, so you get less filtration happening, right? Again, this is why physics is kind of important for understanding some of these concepts here, especially with like the pulmonary system, cardiovascular system, understanding, okay, what are pressure differentials? How does that affect flow in different directions? And in this case here, by losing the Ang2 acutely, that causes an acute decrease in GFR. So if anything, you can still use in those patients, just start low dose and titrate up gently, and they can tolerate it then. If it's a young patient, who cares, right? They don't require the Ang2 to really keep the filtration pressure up. They have other means to compensate for that. So Katie's asking, are third-gen beta blockers a mix of selective and non-selective? They're more so on the non-selective side there. I'd still be cautious if I had a patient with asthma, giving them something like carvedilol. That's why if I had someone who had like asthma and CHF, like metoprolol succinate is probably the better option there. What other questions? Like I said, you guys are free to go. This will be up if you want to go back later and see if there's any other questions that I've asked, but I just want to give you guys the option. Clotting, can you explain how sodium is retained but it seems like urination will increase? Well, clotting doesn't have any direct effect on urination necessarily, but remember there are compensatory mechanisms that happen that will lead to more sodium retention, right? So, again, it's one of those things where it's a lot of negative feedback loops are all sort of interacting here. So, if you have someone who is inhibiting or decreasing blood pressure and the kidneys start to detect that, that's where they try to increase pressure, right? So part of that is through ADH, part of that is through the sympathetic nervous system, which clonidine is inhibiting. Also, part of it is through the renin-angiotensin system. So to be honest, for most patients, I don't see them on clonidine as sort of like a monotherapy, but it's a very useful add-on agent in a lot of cases. To be honest, though, like in pediatrics especially, the more commonplace I see this being used is either for management of ADHD in some cases, and then also we use it a lot in surgery for analgesia. We use it for a lot of our epidural infusions of narcotics. Like actually, a lot of times we can actually avoid narcotics entirely. We can use something like a local anesthetic like ropivacaine plus clonidine and get really good local anesthesia out of that, and that can actually help to limit how many opioids patients have to use in the surgical setting. So even if you're not dealing with like hypertensive patients, if you work in surgery, you might still run into clonidine with some regularity. So. I think it's interesting. No problem. All right, well, you guys will have a week before the exam, so obviously if you have questions, feel free to email me. The sooner you get them to me, the more likely I am to answer you. So probably 100% if you do it today, and if you do it Thursday night at 1 a.m., it'll probably be close to 0%. So hedge your bets wisely. Otherwise, I will see you guys next week. So thanks a lot, and I'll see you then.